Great, great. Well, welcome everyone here and also everyone who's joining us virtually online. We're delighted to see so many people with much interest in this panel discussion on universal health coverage and the importance of surgical, obstetrics, and anesthesia care in achieving a universal health coverage. My name is Key Park. I'm the Director of Policy and Advocacy for the program in Global Surgery and Social Change at Harvard Medical School. And I will serve as your co-moderator. I am joined by Dr. Tarciccio, whose name is Tato Uribe Reitz, who is an instructor in surgery at the Harvard Medical School and the program in Global Surgery and Social Change. And he's joining us remotely from Boston. So at the opening ceremony last evening, some of you may have been there. Bill Anderson, who's the CEO of Roche, the pharmaceutical company, he spoke vividly about his experience recently breaking his femur in 4 places. And he was grateful that he was able to access the health system that was able to surgically fix his femur and restore his function. However, for more than half the world's population, timely access to safe and affordable surgical care is not an option. Fractures go unrepaired, often leading to permanent disabilities. Mothers with complications during childbirth may die or develop horrible fistulas, and cancers are not diagnosed until it is too late for resection. Through this panel, we hope to highlight the indispensable and indivisible nature of surgical, obstetrics, and anesthesia care in achieving universal health coverage. We have an amazing panel today, and they will start by giving introductory remarks. This will be followed by a question and answer session. There are mics on the hallway here for the people who are attending here in person, and those who are participating online, use the Q&A function to type in your questions at the bottom of your screen. And so Professor John Mira will be starting us off with a framing talk addressing the scope and the magnitude of the gaps in surgical care and the remarkable momentum that is building to strengthen surgical systems in the low and middle income countries. Professor Mira is a plastic surgeon in chief at Boston Children's Hospital and is the director of the program in Global Surgery and Social Change at Harvard Medical School. John, good to see you. Over to you.
Keith, thank you very much. It's wonderful to be here, and I'm so honored to be on this panel with all the other esteemed panelists. I'm going to provide just an overview or foundation for which we can then discuss more recent issues with global surgery. I want to give a little bit of a historical background, first of all. So in terms of the evolution of global surgery, I want to start first in 1980 with Dr. Halfdan Mahler. He was really the first global leader who linked surgery and social inequity. So here's a quote from Dr. Mahler: "The vast majority of the world's population has no access whatsoever to skilled surgical care." And then later on, he goes to say, "I beg of you to give serious consideration to this most serious manifestation of social inequity in healthcare." So linking access to surgery and social equity and justice. Now, if you fast forward a few years, this is what is now a relatively well-known article in global surgery circles. This is an article from Paul Farmer and Jim Kim. And I'm sorry it's so small here, but you can see they call global surgery the neglected stepchild of global health. And that was a very vivid metaphor, and it really galvanized the global surgery community. And then in 2015, we saw the World Bank publish Disease Control Priorities 3, and their first volume was Global Surgery. And then the Lancet Commission also published its findings in 2015. And most importantly, the World Health Assembly passed WHA Resolution 6815. And this called out and really codified that strengthening emergency and essential surgical care and anesthesia was a component of universal health coverage. Now, I'd like to just spend a moment on the Lancet Commission. I was involved in this commission, and it really produced 4 outcomes or outputs. The first was clarifying a vision for global surgery, that we should have universal access to safe, affordable surgical and anesthesia care when needed. The second was 5 key messages. The third, 6 indicators, and this is something that Richard Horton from the Lancet asked us to do. And then the last was this concept of National Surgical Strategic Planning. And we originally called it National Surgical Planning, and it's come to be known by an acronym, NSOAP, National Surgical Obstetric and Anesthesia Planning. Now, the key messages, there were 5. The first, you may have heard that 5 billion people lack the kind of access that most of us would have. The second, 143 million additional procedures are needed, and that's on a base of about 300 million globally. The third is that 81 million people face catastrophic expense seeking surgery. The fourth was an investment message, and this is quite that, that surgery is an investment, it's not just an expenditure, and that 350 billion investment in low and middle income countries over a 15-year period could add possibly 12 trillion to those economies. And then the fifth, this was a quote from one of Jim Kim's addresses to the Lancet Commission, was an integrative statement that surgery is an indivisible, indispensable part of healthcare, that is not a separate entity, it's not a side project, it's not a vertical type of intervention, that it really ought to be integrated into national health priorities. As for the indicators, we came up with 6 that are conceptually, I think, fairly straightforward, but often not so easy to collect. So the first is, what percentage of the population is within 2 hours of a hospital that can provide safe surgery? The second, what is the surgical workforce? Third, surgical volume at a national level. The fourth, how many people are dying after surgery? So kind of the most basic quality and safety measure. And the fifth and sixth related to, what is the financial impact of patients and families who seek surgery? Now, the importance of data is that it then can be introduced into the broader health community. And this is what we've seen happen. For example, in 2020, in the Atlas of the Sustainable Development Goals, you can see how they juxtapose two segments of our data. One is risk of catastrophic expense, and you can see the columns here that are juxtaposed against specialist surgical workforce. So this is really one of the first times that surgical data was incorporated in this way. Now, this is that fourth outcome or output from the Lancet Commission calling for national surgical strategic planning, looking at at least 6 different domains. And I'm going to talk a bit more about that in just a second, but I'd first like to let you listen to Dr. Tedros. He gave a wonderful opening at one of the global surgery meetings in Dubai 2 or 3 years ago, and he does such a nice job summarizing things. I'd like to just allow everyone to listen to this.
Lord William Itangi, Professor John Miara, Dr. Walt Johnson, colleagues, distinguished guests, ladies and gentlemen, greetings from Geneva, and thank you for the invitation to speak to you today. And I'm really sorry I can't be with you in Dubai. As you know, surgical, obstetric, and anesthesia care is an essential part of every health system. No country can achieve universal health coverage unless its people have access to safe, timely, and affordable surgical services. 9 of the 13 targets in SDG 3 will never be achieved without improved surgical care. And yet, globally, 5 billion people and 90% of the world's poor lack that access. It's therefore vital that countries invest in surgery. WHO estimates that globally investments of $350 billion are needed between 2016 and 2030 to build appropriate surgical systems. Failing to make those investments could result in losses of more than $12 trillion. As part of WHO's transformation, we will be engaging in much more strategic policy dialogue with countries to identify health systems gaps, ensuring that all countries invest in surgery on the road to universal health coverage. Thank you for your commitment to this very important issue and for your support as we work together to promote health, keep the world safe, and serve the vulnerable. I thank you.
So a wonderful summary, and I have to thank Dr. Tedros because of his support and because of many others, quite frankly. This is what we're seeing in terms of national level surgical strategic planning. A number of countries are embarking on this journey. Well over 20 countries are doing this. Also, the Western Pacific region of the WHO, they incorporated global surgery into their 21st regional committee meeting. And in fact, also passed a resolution in October of 2020, calling for what they call an action framework for safe and affordable surgery in the Western Pacific region. So that is essentially the analog of national surgical strategic planning. And we've seen a whole process move forward in the Pacific Islands because of this. Now, one of the last things I want to talk about is funding, and I'll call out the US government here. So USAID, everyone's familiar with USAID, but what many people don't realize is that USAID can only spend money if there is a congressional mandate. And that comes in the way of what's called the State Foreign Operations Bill. It's called the SFOPS bill. If there is no language in an SFOPS bill, USAID cannot spend money. And I want to call your attention to the yellow highlighted area because this is the first time that there has been explicit language around surgical expenditure. And I'll read this because it's very small. It says the committee supports efforts to strengthen surgical health capacity to address issues such as cleft lip and palate, clubfoot, cataracts, hernias, fistulas, untreated traumatic injuries in underserved areas in developing countries, including training local surgical teams to provide safe, sustainable, and timely surgical care. And this is an important part, assisting ministries of health to develop and implement national surgical obstetric, trauma, and anesthesia plans. Now, this is also a critical sentence. Not later than 90 days after enactment of the Act, the USAID administrator shall brief the committees on appropriations on the planned uses of funds for these purposes in fiscal year 22. So it's really remarkable. Congress is essentially approving expenditure for national surgical strategic planning and asking the administrator to come back 90 days after this act and report on plans for USAID. So this is a dramatic shift in USAID funding. So in closing, I'd like to point out 4 things conceptually about global surgery. One is that it really needs to be integrated into national health priorities. This is not a vertical intervention. The whole surgical ecosystem needs to be part of national health prioritization. The second, global surgical care delivery can help in the achievement of UHC and the SDGs. The third is that there seems to be a change in financing and funding, at least at USAID level, and I'm hopeful that that will carry on to other funders. And then the fourth, which I didn't have time to touch on, but I think our panelists will probably touch on this, that we've seen with this past pandemic that global surgery capacity or surgery capacity and surgical workforce has a lot to offer in terms of pandemic response. So with that, thank you all. And Key, I will turn the baton back over to you.
Thanks, John. We just heard actually at the last session, Dr. Uribe talk about strengthening health systems and investing in workforce and as part of pandemic preparation. And I would argue that investing in surgical system is one of the best buys because it's dual use. It could be, the capacity is practically of importance to the health systems. Tato, I'll turn it over to you to introduce the next speaker.
Thank you very much, Key, and thank you, Professor Mira. Good afternoon, everyone. Thanks again for joining. Our next speaker is Dr. Jafarian, who will be joining today in place of Dr. Nono Simelela. Dr. Varghese is a cross-cutting lead for NCD and special initiatives at WHO. He has been with WHO since 2001, and we have invited them to speak about the WHO's comprehensive approach to ending cervical cancer with a focus on the role of surgical care. Dr. Jafarian, the floor is yours.
You're muted, Jafarian.
Oh, sorry. Okay.
Yeah.
Hi. Good morning and good afternoon, everyone. Thank you very much for giving WHO an opportunity to speak at this important panel looking at global surgery. I stand in for Dr. Nona Simelela, and we just wanted to highlight the importance of cervical cancer elimination initiative. Cervical cancer is a candidate condition that can be looked through surgical eyes as well as equity. It is one of the most inequitable diseases in the world. The incidence of cancer of the cervix reveals that the global inequities exist in prevention, screening, and accessing treatment. In fact, the death rates are 3 times high in low and low income countries compared to high income countries for the same disease. So the WHO has come up with a global strategy to eliminate cervical cancer. And the strategy says that by 2030, 90% of girls aged 9 to 14 should be vaccinated. 70% of women should be screened and appropriately managed, where again surgical capacity comes in a big way. And 90% of women diagnosed with cervical cancer should be adequately managed. This is possible only by working with surgeons, with gynecologists, obstetricians, and across the board on a care continuum. And the integrated approach is very critical here, starting from primary health care, through screening, through pre-cancer management, right up to management of invasive cancers. So I think we think that using cervical cancer as a platform, we can highlight the inequity and bring in additional surgical capacity that is urgently needed across the care of continuum for women with cervical cancer, right from pre-cancer management, right up to palliative care, which is, again, let me tell you, being somebody who has treated a lot of cervical cancer, it is one of the most difficult situations in life, with multimorbidity manifesting in cervical cancer and with financial and social ostracization. So I think surgery being inequitable is actually a crime, and that is manifested in cervical cancer. So WHO stands together, and we also work with the surgical program in WHO and with the maternal child health program to make sure that every woman who needs surgical support, especially in this particular disease that we want to eliminate, are provided with that kind of support. So I'll stop there with my opening remarks. Thank you.
Thank you, Jafarian. It's good to see you. You talked about cervical cancer, which is obviously one of the most inequitable conditions, especially in LMICs. But you're the lead for the non-communicable diseases at WHO, and as a surgery is an intervention, it's cross-cutting, and so we interact with maternal health, injuries, cancers, strokes, all aspects of health system. And I think it's great to have you here, and we'll dive into that a little bit later. So I have a pleasure of introducing Natalia Kanem. She's a physician. She is the UN Undersecretary General and Executive Director of the United Nations Population Fund. And the UNFPA is the UN's Sexual and Reproductive Health Agency. And we've asked her to speak about the agency's efforts to reduce maternal mortality and complications of birth and the importance of safe obstetrics care. You have the floor, Dr. Kanem.
Thank you so much, Dr. Key, and also Dr. Tato for welcoming us. I thank the Harvard Medical School. Excellencies, distinguished panelists and participants around the world, I'm happy to be here today because this session, I hope, will shed some valuable insight into our shared commitment on Sustainable Development Goals number 3 on health for all, and also number 5 on gender equality. UNFPA indeed is the United Nations Sexual and Reproductive Health Agency. Everything we do is based upon population data and evidence. And we constantly have to ask ourselves the question, why? Exactly who is being left behind, and why is that happening? And in many parts of the world, the sad truth is that the answer to that question is women and girls, particularly if from marginalized populations. Women and girls have the least access to health services. They're also often harder to reach. And this is particularly the case in poor and rural parts of the world, precisely why 800 women die daily from complications of pregnancy and childbirth. I will hasten to add that the woman who is dying from pregnancy and childbirth complications very often is a girl under the age of 18, whether legally married or not in her home country. She's not mature enough to carry a pregnancy. And now with COVID, the pandemic-related disruptions and the movement restrictions that have made certain women fearful of leaving the house and going to seek antenatal care have further hindered access to sexual and reproductive health services overall. For obstetric care, that implies, and we've seen, increases in unsafe abortions and in childbirth complications, and therefore to potentially thousands of preventable maternal deaths. And the growing inequities that were laid bare by the COVID-19 pandemic have been there all along. In recent years, for example, the alarm was sounded by Miller et al., writing in Lancet about the inexcusable paradox that we see in maternal health. Too much, too soon, and too little, too late. What they were referencing is the routine over-medicalization of normal pregnancies and births, and then the inattention to high-risk moms in the least developed countries. On the one hand, the massive rise in elective cesarean section, the unnecessary use of non-evidence-based interventions, and on the other hand, yes, the more than 800 women and girls who are dying each day from complications that could have been prevented if not for a lack of basic health services, the skilled hands of a surgeon or that anesthesiologist who is not available. So when I think about universal health coverage, what I think is vital for equitable access is to promote the health of the woman and the newborn and to meet the needs of the most vulnerable. So you look for the hardest situation to solve, and that's going to benefit others. And we don't start at the moment of the pregnancy. We have to think about an adolescent girl and protecting her, giving her the understanding of her rights, her choices, so that she's aware of what she's embarking on, or we prevent her from being coerced if that's at issue. As we have heard already, more than 5 billion people globally lack access to safe, timely, and affordable surgical care. And that does, in fact, lead to millions of deaths each year. And when UNFPA, which works in over 120 countries in the developing world, when we see a government with a limited budget, limited capacity, and having to make these life-altering decisions about what to include in any universal health coverage or national health plan, we ask them to please consider the far-reaching sexual and reproductive health needs of their populations and how these will be met. And I'm glad the Honorable Minister is with us today, and I'm sure we'll hear from her. In 2019, the monitoring report for global UHC indicates that reproductive, maternal, newborn, and child health, the RMNCH component of the UHC service coverage, was barely above 50% in low-income countries. So in monitoring that indicator, we've tried to demonstrate the benefits of the package as governments decide what surgical procedures are to be included, and how and who will receive those services, and how do they get paid for. Ultimately, obstetric fistula, which you referenced already, Dr. Key. To me, that is the prime indicator of how a poor woman and a girl is excluded from care, how she's forgotten, how she's left behind. Fistula, a wound of the uterus, occurs because of prolonged obstructed labor. Skilled hands are not there to provide the medical care, including timely access to emergency cesarean section. And in many cases, the baby is stillborn or will die within the first week of life. If that weren't agony enough, it also leaves the affected women with a hole in the birth canal, sometimes in the rectum, which causes them to leak urine or feces uncontrollably. And this is stigmatizing, to say the least, leading to a life of a kind of exile. Some of the happiest moments that I've witnessed is being in the post-op recovery section of a fistula hospital and seeing the recovery of these women, although some of the cases can be quite difficult and complex, the sense of belonging that returns, the sense of dignity that returns to this woman. And yet, in many low-income countries, financing mechanisms for the treatment of fistula are virtually non-existent, and that deters many women and girls from being able to take the bus, go to the big hospital, and apply for the surgery that can be so life-changing. What UNFPA has done about this, together with our partners, is to launch a global campaign to end fistula, and it's working right now around the globe to increase awareness about protracted labor, to drive action if fistula occurs, and to provide funding mechanisms so that the poorest women can access the surgery that they need. Still, an ounce of prevention, it is a truism, is worth a pound of cure. So if underserved populations only had access to better emergency obstetric services, and if healthcare providers from the primary level on up understood and paid attention to this problem, then we would have, rather than too much too soon in certain countries and too little too late in others, a balanced health system, which indeed looks after and safeguards the well-being of all women and girls. Let me leave it there and happy to engage further.
Wow, it's great to have you explain it in your own words, how these conditions form and why it's so urgent more than ever to address these surgical issues. And at the last session that we just finished, you talked about a very alarming statistic, which is there's been an increase, maybe perhaps as much as 70% in maternal mortality ratios in some of these countries as a result of the pandemic. And we'll get into some of that later, but so these numbers that we're talking about are pre-pandemic, and the pandemic really has created a sense of urgency more than ever, I think. Tato, let me turn it over to you to introduce the next speaker.
Thanks, Key, and thank you, Dr. Canham, for that important message and the meaningful work that you do at UNFPA. Our next speaker is Professor Jafarian, who is joining us virtually from Tehran. Professor Jafarian is a highly accomplished surgeon and leader. To highlight some of his accomplishments and leadership positions, he was Dean, Vice Chancellor, and Chancellor of Tehran University of Medical Science, his alma mater, and is now member of the Board of Trustees. We have asked him to speak about educational pathways for surgical care providers in low and middle income countries, and to share insights on strategies for scaling up surgical workforce, including primary care providers, obstetricians, midwives, and anesthesiologists. Professor Jafarian, the floor is yours.
Thank you very much, Dr. Tato. Do you have my voice? Okay. Thank you, the panelists, and I'm very glad to be in this panel, of course, from Tehran, and we are talking overseas with each other, and that's one of the, maybe advantages of the Corona area, because we found better ways to communicate in a wider scope. I was hearing the very great talks of the panelists beforehand, and I'm going to a small sample because most of the talks were about the global issues and what we can do at the global level. But what we can do in a national level, I'm going to briefly introduce you a very short talk on the what has happened in Iran in the past 4 decades. As all of us know, we have 4 pillars of universal health coverage. The first is the availability of service. The second is the resources and equipment. And the fourth is the demand. And the third and the fourth is the access to service of health. if I want to briefly introduce what has happened in my country in the last 40 years, from the first part, which is the availability of service, we had added the infrastructures of community hospitals to the medical universities. This has happened 30 years ago, and we have a Ministry of Health and Medical Education, which covers both the community hospital and university hospitals. And with this innovation, the universities were expanded, and we have much more medical schools, nursing schools, midwifery schools, and so on. So we could produce more graduates on these in these schools. So from somehow 9 medical schools in 1979, now we have more than 70 medical schools in the country, and they are enrolling much more medical students each year. And when we go to the resources, we have increased our residency programs in all the residency programs, including surgery, obstetric, anesthesia, and it is now like 6-fold from the past 40 years till now. And also there is the increasing number of nurses and midwiferys students to the scale that now we have a surplus in midwives, and in some provinces in the nurses. So we do not have any lack of human power in this aspect, and not all the aspects. And one of the other innovation for providing enough workforce was a straight path for residencies. When some specialties were lacking around the country, like the anesthesia, we had a straight path to the residency, and our medical students were going to the residency at the middle of their internship. In Iran, the internship is in the MD, and then you start the residency. So this path made a lot of anesthetists around the country at that time, like 20 years ago. But when we go to the demand is still high, and the people need a lot of, in any small city, you need, the people need some, hospital facility and so on. That made the government and, the resource allocators to make some and construct some small hospitals like 64 or 96 bed hospital. And these hospitals now are around the country, but they are not so effective, because maintaining these hospitals and providing a human workforce and also facilities and equipments is a huge cost. But there is, and that's because of the demand. And the parliament usually, force the government to make these small hospitals around the country. And then if they do that, they have, answered a demand. But if they do not do that, they go for the bigger plan, like mega hospitals and transferring the patients, there is at least in the short term, it is not convincing for the people. And also we have some referral system between the small cities to the center of the provinces, and from center of the provinces to the tertiary care hospitals in the country. And when we go to the access is somehow difficult still in Iran. We have a very good primary healthcare system around the country, which is like a pivotal in the world maybe, and it is well established in the villages. But when the amount of the people who are living in the villages is low, is decreased from 70% to 30% now, and the amount of the people who are living in the cities and suburbs is now 70%, we have to switch to the towns and big cities and suburbs of the cities. So this needs like a change in the plan of the primary health care. But this is also done. This is also underway, and the government is planning for that, but in the middle of it. And if I want to shortly mention about the COVID era, which was a problem for the whole world. The surgery department were one of the first one who made a new plan for emergency and essential surgeries. In my division is the hepatopancreatibuliary and liver transplant division. We were maybe the first one in our hospital, which is the biggest hospital of the country, to make a new plan that which patients should be operated and to how much we can decrease the facility usage of the hospital to serve the COVID patient when we went to like 500, 400 COVID beds in a 11,000 bed hospital. So that was the first step that we could plan. And the next one was adding the surgical workforce to other physicians and specialists who were working on COVID patients and helping them. And at the meantime, we were going to do the liver transplants section as a necessity for the country, because if there is a brain dead donor and if there is the facility, you could not defer the transplant. The same thing is the working of the anesthetist, which was very important and very effective in the COVID pandemic, and was a very big problem to have enough anesthetists to cover the ICU beds. That was, made it very evident that how much anesthesia specialists are needed around the country and in the big hospitals. And that was a very big problem in the, especially at the beginning of the COVID pandemic. So if I want to end up with the achievement, we had increased the number of human workforce. We made a very better distribution of those. In Iran, we have a mandatory service for all of the graduates from the medical universities. So they have to serve in suburb and in peripheral and in the countrysides and peripheral cities. And this is from 1 year even to 8 years based on how they started the residency program. And so we decreased the number of referral to cross-border countries, and we decreased fetal and maternal mortality as to the SDG levels. But what we have now and what is the challenging is how to keep these people in the peripheral areas of the country, which is a difficult issue. Maintaining them there is not very easy to do. The problem of payments, and making facilities, and the number of the patients who are coming from each small area, and how much workforce you should trap there. These are the problem. And in some areas, the overproduction, like in midwives, we have overloaded with the midwives, and many of them are now out of work. So this is another problem when you go to distribute all the facilities. Thank you very much, and I want to stop at this point and listen to the other speakers. Thank you.
Well, thank you, Professor Jafarian. We have a representative also from the nursing community, and I had a privilege of attending their session yesterday. And one of the statistics is there's a gap of 6 million nurses today. And it seems like for Iran, you're an outlier in the sense that you've been strategically planned your nursing workforce and healthcare workforce, and you're reaping the benefits of that. So first, let me just thank all the panelists for coming, especially Natalie and everybody joining online. I know everyone is busy, but I can tell you that the ministries of health have to be the most busiest people at the moment because of the pandemic. I want to say special thanks to Honorable Minister Leah Tadesse for joining today. She's trained as an obstetrician gynecologist. She's worked in academia, managed programs at NGOs, and now works in government. She's the Federal Health Minister of Ethiopia. Notably, Ethiopia has been a leader when it comes to national surgical system strengthening. So I'm thrilled that she's able to join the panel today, talk about how Ethiopia has managed to scale up their surgical care services. And we also want to get an idea of what's happened to the surgical care delivery in the context of the current pandemic. Over to you, Minister Leah Tadesse.
Thank you so much. Thank you for the kind introduction, and pleasure to be part of this esteemed panel discussing this very important topic. As you are all mentioning, essential and emergency surgical interventions have been prioritized in Ethiopia's strategies and revised essential service package as part of our commitment to achieve universal health coverage. And of course, to start from the impact we had in this COVID pandemic, especially in the earlier time of the pandemic, the first probably 6 months or so, there was a challenge and deterioration and provision of non-COVID essential services, including essential surgery, because of the extensive measures taken in public health and social measures that were taken to help mitigate the pandemic, while we're especially making our facilities ready to serve for COVID patients, and also the uncertainties in how to manage and provide services within the pandemic, compounded with, of course, the fear of communities. So, but we quickly, within maybe a couple of months into the pandemic, we quickly established also a parallel task force that was working with the COVID response to ensure continuity of essential services. And one of the prioritized services was definitely essential surgery, particularly emergency surgery. So by integrating interventions like using rapid testing and others for all patients who required surgery, and of course, now that we are also accessing vaccines to our health workers and communities, this has really improved. So now we are back to the pre-COVID statistics we have, and even in some areas getting better. And when you look into our overall strategy, we designed and implemented saving life through safe surgeries, a SALS strategy for the last 5 years, 2016, 2020. And we recently revised the next 5-year strategy in collaboration with our regional health bureaus, our partners, and also, of course, the key partners, also the health professionals associations, aiming to improve equitable access to high quality and safe, essential and emergency surgical and anesthesia care. And during this time where we're implementing this strategy the last 5 years, we have, of course, started by establishing a structure that can implement this, starting from the ministry to the regional bureaus, and also establishing these SALS committees in health facilities, by also increasing the budget allocations to improve access to surgery at different levels. And with this, with the different interventions, the surgical workforce development both at pre-service and in-service has been expanded, which has also resulted in significantly improving our surgical volume. Infrastructure has been a key priority, and especially in enhancing surgical services in primary hospitals and also in primary healthcare centers has been one focus area as a ministry, because access to safe surgery, definitely we are very far from where we want to go. So we cannot only rely on our general hospitals, but ensuring that there is more access in our primary care centers has been a target. So we have been expanding our, constructing operation OR blocks in our primary care centers. So in the last 3 years, 400 health centers have constructed OR blocks, but of course, it's not only the construction that's key, it's equipping them and making them functional with the needed workforce. So we are only able now to make around 10% of them functional. So it's one of our big focus areas this upcoming year, and to make this functional. We've also been working in increasing our oxygen capacity. This is key for the surgical services, but of course, the demand has been compounded with the pandemic, but we have been also using the pandemic as an opportunity to expand our oxygen capacity nationally. And since even the pandemic, we have tripled our oxygen capacity nationally using both public and private sector engagement. In the intervention, in the implementation of the strategy, one of the key areas was also incorporating key surgical care key indicators into our M&E framework. So some of the key indicators like surgical volume, surgical site infection rates, adverse outcomes from anesthesia, perioperative mortality have been included in as our key indicators, which are monitored very regularly. So these were tracked, and quality safety improvements projects were also designed and executed in this period. We have also implemented the surgical safety checklists nationally, which has helped us bring a positive impact on the reduction of perioperative mortality and other surgical side effects. And towards strengthening this system beyond only the strategy, we have, in addition to the strategy and these infrastructure developments, one of the key focus areas has been the development of the medical specialist and mid-level healthcare provider training plan that we have from 2020 2030. And there are key focus areas in this when we think of surgical services. One is, of course, a national plan that this national plan mainly helps us to provide a framework of investment from government and partners. And it's anchored to also bring newly developed rigorous standards for existing training programs and to bring all specialty training programs in the country up to the same level of quality. It's not only about expanding the training services, but also improving the quality of the training programs that we already have. So we are, to improve this quality, we are looking at equipping these training facilities, especially the simulation labs and others, and also the critical issue of having the needed faculty and enabling environment. So we're focusing especially on 12 major teaching hospitals. And the focus areas on this training plan is, of course, like training high quality surgeons that can immediately contribute to this unmet need of more than 5 million surgeries annually, while reducing the wait times, which compromises the outcome, as we all know. So while we invest on the infrastructure, we're also trying to invest, but we are also trying to mobilize more resources for these trainings, which will require, for example, an investment of about $2 million USD can ensure the infrastructure demand is made for at least 3 new training institutions within the country to improve surgical services. The other key areas are high quality OBGYN specialists and highly competent midwives, because maternal mortality is still a key challenge where surgical interventions and C-section rates need to be improved nationally. We are still at 4% of C-section rate nationally, which we can see is very low. So this is another focus area. And we have also opened anesthesiology postgraduate programs this year, which require additional investments to train faculty and sustain these programs for the long run. My last one in terms of the training programs is the focus we are giving for emergency and injuries. So these are also a key focus area in terms of the training programs. So we have, in addition to the training in terms of emergency and critical care and injuries, we have incorporated in our strategy community interventions for early detection, including activation of systems, the pre-hospital services and toll-free numbers, as well as a strong appropriate linkage with treatment facilities for timely care and rehabilitation. And we have also been working by engaging university hospitals, linking them to city administrations for this stronger emergency response and timely surgical interventions for emergencies. So it has been a challenging time with the pandemic, but we are also using it as opportunity. But this is really key to achieve the universal health coverage that we are all envisioning. And we do hope that we get more partners to support and collaborate with us in the way forward. Thank you so much.
Wow, Sakanalo, Minister, that was amazing. You know, we work a lot at different levels with the surgeons or public health officials in Ethiopia, and I always come away so impressed. I'm not just, there are other countries too, but I just want to just say a special comment to the Ethiopian colleagues that I've had a pleasure to work with. And you know, right now there are neurosurgeons. I'm a neurosurgeon by training, who are organizing a conference this week on prevention of injuries. And I think that's brilliant, because we're surgeons and we think ourselves as, you know, curative services, but prevention to us also helps us reduce that burden so it can be more effective. So I'm just really, I'll be participating in that particular conference. I think it's Thursday. So let's start with some questions. I think Tato, you have some questions to start.
Yes, I would like to echo Key's comment. Thank you very much, Minister Lia Tedeschi, for taking the time today to share your experience, and in particular, special thanks for being a champion and a leader to improve access to surgical care. So the question and answer section, we will start with a general question to all panelists, following the same order of your talks, and then ask you to please keep your answers to no more than 3 minutes. And here's the first question. It's 2021. We're just 9 years away from 2030, the target date for the SDGs. The pandemic has dealt a crushing blow to health gains. What do we need to do differently to achieve universal health coverage by 2030, at least in terms of surgical, obstetric, and anesthesia care?
So we'll go with John first.
Yes, please.
All right, well, thank you. What do we need to do differently? Well, I guess if the we as countries, I don't think it's for me necessarily to say what individual countries should do, but I would, and what I think I can do is point to the tremendous success in Ethiopia and what Minister Tedesse has done. And she talked about the SALTS program and went through, over a dozen itemized things that they've done. And I was carefully taking notes, and it's remarkable what they've accomplished in a relatively short period of time. And you see, they were one of the first countries actually that had a national level surgical strategic plan. It was called the SALTS initiative. And you saw what that did is it actually, by way of their leadership, you see other countries that looked at that and said, we can do that. And so then you saw the Southern African Development Community, pass a resolution, and you saw the Pacific Islands and Wipro get involved. And I think that type of leadership can really bring about changes and not, surprisingly, it's all occurred since 2015. So this is not something that needs to take 20 or 30 years. I think the kind of leadership that Ethiopia has shown can really change countries and regions dramatically.
Thank you, Professor Mira. Next, we'll have Dr. Varghese, please.
Thank you. First of all, let me congratulate Iran and Ethiopia for the excellent work, including in the area that I deal with, non-communicable diseases. Both countries have shown substantial improvement in NCD prevention and management. So congratulations to both countries. Yes, we have less than a decade to achieve very ambitious targets. In fact, if you look at the SDG 3, the SDG 3.4.1 is reducing premature mortality from non-communicable diseases by 1/3. That is in the age group of 30 to 69 years. And if you look at those 4 diseases, cardiovascular disease, cancer, diabetes, and chronic respiratory disease, surgical interventions are critical across the 4 conditions. So we think that the UHC benefit package, as countries are developing, Ethiopia has developed, Ghana is developing, we are supporting other countries, is one of the first way to ensure that surgical interventions are very much part of the nationally funded minimum benefit package under the universal health coverage. And that should be really factored in, not just passed by. We have to really say, and I just wanted to use the example of the country where I come from. In India, there are public health standards now laid for a district hospital. So what are the surgical interventions that should be available at a district hospital? Who should be able to do that? What are the infrastructure requirements? While this is generally known, we think it is important to write down, lay it down, and check the hospitals against these standards, because unless we get into that level of rigor, we are not going to sort of have the scale up of service that we really want to do. The short-term capacity building is something that we really have to look at. We are working with the United Nations Institute for Training and Research in a surge capacity for surgical oncology. We have just done it in Zambia. We'll be expanding into Rwanda and other countries. This is again because we don't have the luxury of 8 to 10 years of surgical specialty residency training in many countries where women and men are dying for acute surgical intervention needs. So I think again, using the new methods of digital delivery as well as remote support, we should be able to sort of decentralize some of the services. We just looked at a delay in care. If you look at a woman with breast lump in most parts of the world, it will almost take 9 months to 1 year for this woman to get definitive treatment, because she will go to some primary care, some other hospital, she will come back, the surgery is not complete, biopsy is not complete, pathologist is not there, mastectomy is not done, radiation is not followed. For a tumor that could have been easily cured with 90% cure rate, with the system inefficiency, the tumor almost becomes double the size and becomes stage 3 when the survival probability becomes 10%. So this is something that we really need to keep in front of our eyes when we look at the next 10 years, how to have the surge capacity in terms of rapidly ensuring even anesthetic capacity. I have seen of places where paraprofessionals are given anesthetic training just for certain procedures and to get them to board immediately. And then make sure that surgical interventions are covered with the financial protection that countries are providing for many of the interventions, as well as making sure that the public-private sector engagement is made appropriate. Let's face it, in most parts of low and middle income countries where there is no standardized national insurance program, private sector is the main provider for complicated procedures for most of the non-communicable diseases. And this sector, which is sometimes completely out of government's overarching programs, have to come in such a way that there should be a seamless service between public and private, especially when it comes to surgical capacity, pathology capacity, etc. And this is something that that is currently adding to the delay that I have just mentioned. So the time is very short. We have to collectively act and make sure that again, the person who is needing it most is the one getting it least. That's what we always say in most of the global programs. So I think starting with where it is really making a difference and then working the way up and using all measures to ensure that we have an integrated approach rather than sort of fractioning the minimal resources and capacity out there. So WHO is monitoring the next UHC service coverage, getting ready. Again, we have to really show, as we have heard already, the improvement in UHC service coverage index is not optimal, and we need to really scale up that. Thank you very much.
Thank you very much, Dr. Varghese. We'll have Dr. Kanem next.
Well, thanks very much, Tato. And I'd like to join in congratulating Ethiopia and Iran, where UNFPA has established programs and has been working on these issues together with government over the years. Regarding the question, I would just say the most important thing is to keep 2030 and don't back off the date. There have been daunting challenges, obviously, but healthcare is an established human right. And the UHC mechanism must prioritize comprehensive emergency obstetric and newborn care services, including timely C-section. Surgeon, anesthetist, midwife, family, the woman herself. And then, of course, the funding of government and the private sector to back a well-functioning health system. Time and again, we've seen that these are critical interventions to assure a safe passage through childbirth for the woman and for the newborn. So supporting the type of national and local surgical service networks that we've been hearing about is really important. At the same time, though, there's still a disconnect. The unbalanced geographic distribution of trained personnel that John Miara and other people alluded to. And that does contribute to inequitable health outcomes if you're trying to reach those furthest behind, that nomadic population, that isolated village within an island nation or wherever it is. I believe that we have to invest more in training. And that training should come at the community level. It should continue to support career development along a path for the nurse, for the midwife, because in fact, she is the backbone of the maternal health systems in the developing countries that we're discussing. And it's also important to measure, to have agreed upon indicators, and that's what the SDGs are helping us to do, so that we make sure we have access, but also to quality services and care. What gets measured gets done. And my last point is to consider who are our stakeholders in the UHC efforts in this arena. And we'd have to say women's groups and youth groups and the survivors of fistula, of reproductive health cancers, anyone who's been a victim of a non-functioning system, the private sector, of course, but another important non-health actor is the parliamentarian. These are the people who hold the power of the purse, and they devise the legislation and appropriate the budgets, and do the work to remove the barriers to universal coverage. I also would have to say it would help if we, as we advocate for the surgical, obstetrical, and anesthesia, that it would help if we would break down some of the technical jargon and allow the regular person to understand what our aims are, so that we can translate those global UHC commitments into concrete national action. Technology and innovation are going to play a role here. One example is how supply chain management, big headache with COVID, but it can be optimized by developing alternative key obstetric products that wouldn't require a cold chain. That's been a recent example with the stable carbetocin and the tranexamic acid. So the supply logistics, but also innovation. So we bring new solutions to the issue. So again, the surgeon, the anesthetist, the midwife, the family, but especially the woman herself, understanding health as a human right, and then the funding and the backing to make it happen. Thank you.
Thank you very much, Dr. Kanem. Next to Professor Jafarian.
That's a very good question, and I just want to mention what we learned all from the COVID pandemics. I just want to make a very evident comparison between the military and the healthcare workforce. If you see the military service, in many countries, the military service is not doing any war for the whole life, but they should be there. And that was the same thing that we could, understand from the pandemic of the COVID in the world, that the healthcare system should be redundant. If we want to be resilient, we need some redundancy. And that redundancy in the healthcare needs budget, needs infrastructure, needs whole workforce and everything else. I hope that the whole countries, that as now the lady said now, the whole country, the parliament, the government, everybody should understand that when we talk about the surgeons, the obstetricians, the anesthesists, these are not those guys who should work round the clock, but we need them because many things may happen and we cannot be faced with them with enough background. So this redundancy is one of the mainstays that we learned from the COVID pandemic, and I hope that everybody in the world would learn that. And the second thing that I want to mention is that in Iran, we set a very high standard for anybody who is doing surgical obstetric anesthesia care, because all of them should be a specialist and all of them should be board eligible. Otherwise, they could not practice. This is, in that way, this is a very good, high standard. And on the other way, it is an expensive standard because, the education takes a long time. They have to pass 7 years of medical school and then 4 years of residency in all of these 3 specialties. So it is at least 11 years. And that at that time, they can do their independent practice. So in this way, we have a very high standard. And we should consume that. We should think that the complication rates would be low, but it is an expensive, and doing this takes a long time for those guys who are going to in this service. Thank you.
Thank you very much, Professor Jafarian. Minister Lia Tedesi.
Thank you very much. I think most has been said already, but when we are in this especially pandemic, we are always thinking of how do we make our systems resilient, even when we are thinking of sustaining such programs. And one of the key things I would like to emphasize is really the investment on the primary healthcare system, especially when we talk about countries like ours, where we have a lot of population in the rural areas who cannot access those bigger hospitals. Ensuring access to safe surgery in primary care hospitals and centers is, I think, critical. Decentralizing all this key services to NCDs, injuries, and other key essential surgical services. So investing in those would be key. I think that would also answer to one of the chat box questions I had seen on how to access to the rural population. So that would be really key, and that would give an opportunity for those larger hospitals to really focus on those more complicated services. Otherwise, all the cases that can be served at primary care level are usually going to those bigger hospitals, which compromises the quality of care in those hospitals as well. So really building that capacity would also help us create a resilient system for any other challenge like the COVID pandemics that we have when we have a system that is really decentralized. But to achieve this, I also want to emphasize a financing issue, which was also mentioned by Dr. Natalia, because it is, of course, the resources that we allocate that determines how strong the systems will be. So governments and donors focus on investing in this area, in improving this surgical care is really critical, as well as, of course, the engagement of private sector. And the last one I want to mention is the training aspect on the workforce. So it's, of course, the expansion, the quality of training that we have already mentioned, but making sure that the training programs that countries have is sustainable. It could be through twinning with other institutions, but building that internal capacity that can sustain a strong training programs for the way forward, not something that is only dependent on external support, but a program that can sustain itself once the capacity is built. So I think this, if we focus on those areas, we can have a good progress on achieving the goal in 2030. Thank you so much.
Fantastic. I want to give some time now for the participants here and also online to ask some questions. And hybrid means hybrid, and so we will be fair. We'll take a question from here and we'll alternate with the online audience. So if anyone has a question, please line up behind the microphone. And then for now, let's go ahead. Tato, do you want to pick a question from the ones that have been raised online?
Yes, thank you very much. Thank you also, Minister Tadesse. You already addressed one of the questions, so we'll move on to the next one. Thank you. We have a question from Emma Bryce from Kids OR asking, how important is pediatric surgical care, particularly ensuring provision of specialists, pediatric and neonatal surgical equipment in wider surgical care plans? I'll leave it open for any of our panelists to.
Well, I'd be happy to say a brief word on that. Being a pediatrician, I am biased, I suppose, but when we think of the life course of someone with a disability and something that can either be surgically corrected or ameliorated, it becomes really important to plan properly. I will also say that the rate of accidents that contribute to calamities for young people, they need to be aware of and to understand, the public health measures like seatbelts and speed limits if they're driving, or accidental injuries as they go about their work. I'm going to just sneak in a question myself, having heard the professor speak about the length of time and the expense of having high quality surgical certification, about the experience with parasurgical profession personnel, and in particular for cesarean section, because we're also looking for money-saving endeavors. So I don't know if that was fair, but I wanted to put that out there on the table. Thank you.
So why don't we pursue that line of thinking? I think that's an excellent question. So within global surgery, I'm a neurosurgeon. Dr. Mira is actually a plastic surgeon, pediatric plastic surgeon. And so we have these super specialized titles. And in the context of providing emergency essential surgical care at the district hospital level, it's actually counterproductive to talk about those titles. I want to go to Minister Lia Tadesse, because Ethiopia has been a pioneer in sort of using the midwifery model and expanding it to surgical care with the surgical officer system. Maybe you can talk about that. That was started by actually Dr. Tedros, I think.
Yes, thank you. Thank you for the question. I think it's very important. Ethiopia had started, as you said, when Dr. Tedros was the Minister of Health, a program on integrated emergency surgical officers training, which were actually who are actually health officers by training, which is a 4-year bachelor's public health training. And then they were trained by 3 years master's training on emergency surgery to do C-sections and other emergency surgeries. So many of our primary hospitals now are staffed with these emergency surgical officers who are providing a lot of life-saving surgeries in many primary hospitals. Well, of course, some of them are also working in some general hospitals as well. And when we are now looking to operationalize the health centers where we are putting on our blocks, that we are using the ISOs to also give these services. And it has proven very strong support to improving access to surgery. And also there is another program we're going on, a clinical midwifery master's program, where midwives are also being trained to do C-section. And that's also an ongoing process, which is we are reviewing and improving currently, but that's also a very strong program, which is more recent than the ISO program. But of course, it has also its own challenge, especially now that Ethiopia has been expanding medical schools and training of physicians really robustly. The past few years, we've had actually even difficulty to hire all the doctors who are graduating because of the large number. So we're working to expand our training residency programs. So how do we move forward in terms of such mid-level trainings or parasurgical officers is also under discussion. And also the career paths that they're also have the concerns that is being raised from the professionals themselves on their career path is another challenge. But the impact on the access to safe surgeries has been really tremendous through this program.
I think it would be only fair to offer Dr. Jafarian a chance to comment back.
Just a very small point that, as Mrs. Minister said, this is a very context-based decision. You know, in Ethiopia, this may be the way because they do not have now enough graduates from medical school and residents. But in Iran, it doesn't, you know, and it is not the answer, because in Iran, we have enough graduates, and the, you know, the standards that people accept is much higher now, and we could not, you know, get it lower. So we have to make another decision to continue the way. So it is a very context-based, I think, and in each country we have to find the solution for that country.
That's an excellent answer, Dr. Jafarian. Sharian, do you have any comments from the WHO standpoint on task shifting, sharing?
Yes, task shifting and team-based care is the sort of new mantra, I would say, because far too often we did not get the coverage that we wanted because services were sort of concentrated, and we thought that even certain things could only be done by a certain cadre of people. So I think decentralizing care with some supportive supervision, which is something that we have seen during COVID as an adaptation in many parts of the world, has immediately improved coverage of services. So I think that can be certainly done. In terms of surgical capacity, of course, one has to really measure as to what can be sort of stepped down, if you want to put it that way. But certainly bringing teams together, including even in a district, if there is a surgical team that is ready to meet the needs of the district, being able to be mobile and support operations at different parts of the district, such things have to be really looked through, because we have been hit by COVID and every country in the world has suffered. So this is the right wake-up call to look at and do things differently in terms of decentralizing care, in terms of step-down care, in terms of self-care supported by digital technology, be whatever it is. And unlike what we have been in some countries, I know we have been waiting for 20 years to get guidance on allowing teleconsultation. And come COVID, within 3 weeks, government has issued a guidance on how to go for teleconsultation. So I think we have to build on this momentum. sort of decentralize and sort of socialize many of the medical services with an empowered group of recipients at the other side, but supported by adequate regulatory mechanisms. The Lancet Financial Times series has just come up in the Lancet looking at digital health and how digital health has to be governed globally to maximize its impact. A lot of artificial intelligence is coming in. Cervical cancer screening, again, the area that we are primarily now working as one of the key initiatives, is again looking at the use of AI in interpreting cytology, in interpreting visual inspection, reducing the time. I think in most of the cancers and in many other obstetric conditions, I would even go to the extent by saying that delay is death. And the delay is mainly the provider side. And the provider side is not being sensitive enough to address the delays by taking measures. And this is the right time to do that. And of course, team-based care and decentralization is one of the ways to address that.
Thank you, Dr. Jafarian. We actually have a question from the floor. Please, I'll just introduce yourself and yeah.
I'm Christopher. I'm from the German Medical Student Association, and I have a question relating to pregnancy complications. So I think that would be relevant for Madam Kanem or Madam Leah. You talked about preventing complications as a good way to treat them. And I wanted to know if there are screening tools in development for low resource settings to actually identify the women who are at the biggest risk of developing birth complications and to treat them preferentially and to get them to hospitals to actually avoid emergency C-sects, which will be very difficult in rural settings.
Minister, the Honorable Minister.
Oh, okay. Was that though she said Madame Kanem, but
I think it was both, right? Yeah.
okay. So Minister Leah Tadesse, do you want to take that question? Did you hear that question? It had to do with, is there a way to predict who would be at high risk for developing pregnancy complications so they could be sort of pre-triaged to a facility? I think that was my understanding. All right. So Minister Leah Tadesse, do you have any thoughts about that?
Sorry, my apologies. I had some disconnection in between and had
Yeah, I can repeat.
Okay,
yeah.
well, why don't I start?
Sure.
Minister Leah, we were asked by, what's your name? Christopher from the German Medical Students Association about the training process and how we identify high-risk maternal death potential cases. So we thought you should answer first because Ethiopia has done so much in this regard. And I can say a word about what UNFPA is doing after, if you don't mind. Thank you.
Oh, thank you so much. Well, detection of high risk in maternal cases is done at different levels. So antenatal care is, of course, the key modality where we try to screen for women in pregnancy. As most of our population is in the rural sector, we use, for example, community health extension workers who go house to house to provide prevention and promotion services, as well as work in the lowest level of clinics, which we call health posts, where they do screen provide antenatal care, but they also have to get antenatal care at the primary care centers. And so we screen for the basic lab tests. And well, of course, now as a country, we're working to improve the access to ultrasound screening for pregnant women across the primary care units, but still limited. So not every pregnant woman may get screened. Of course, even some of our pregnant women may not come for antenatal care, but that's, for the most part, is very high now, at least trying to achieve the 4 visits of antenatal care based on the WHO guidance. So the main platform, of course, that we are using is strengthening the antenatal care follow-up, ensuring that they at least have the 4 visits, and one of them has to be at the primary healthcare center. And depending on the identified risk, they would have a referral linkage to the general hospitals that provide these services across the continuum of care. I think primarily this is a key aspect that we are using. Prenatal counseling and preconception is very limited. So the main strategy we are using is the antenatal care. Thank you so much.
Okay. Yeah. Do you want to have a?
I think the minister has answered. I would just add that training is a big part of this, and WHO actually sets the standard. UNFPA, as the Sexual and Reproductive Health Agency, helps countries around the world precisely to do what the minister alluded to. I would say the quality of care is directly related to training and to the issues that were put on the table earlier about the type of appropriate context-based, as Professor Jafarian said, training. And then lastly, I think the illusion of quality is now part of a formal network. It's known as the Quality of Care Network. And our aim is to cut in half the number of preventable maternal and newborn deaths and stillbirths in health facilities. So we'll be happy to share the links for those who have more interest.
Fantastic. Tato, do you have a question from the online audience? And we'll have one more here. So if you do a quick answer, we can get both of them in before we do the closing remarks.
Okay, yes, there's one more here. Speaking about inequities, it's on a global level, how do we deal with the uneven distribution of support to countries? This was specifically asking about how to avoid the work of global surgery being concentrated in certain regions and not in others.
Does anyone want to take that on?
Kia, I have a brief comment about that, and I think it speaks to funding. And you look at what's happening with the U.S. federal government and USAID, and I think it's a call to have equitable funding. And so, with this new SFOPS appropriation bill, how should that be spent? And I think it's, I don't necessarily have an answer immediately, but with a new funding stream like that coming from USAID, equity and justice should be part of their decision-making scheme.
It's a great answer. Anyone want to go on top of that? If not, we'll invite the next question.
Thank you. I'm Naomi Lee from The Lancet. And first of all, I wanted to say thank you for such a hugely uplifting panel, because it's amazing to hear after a commission everything that's happened and all of the fantastic results. We always feel that global surgery doesn't get enough attention. And today, I think we heard some amazing examples. But of course, I did come with a question, not just a remark. So I wanted to say, at the beginning, John Mira told us that global surgery is the stepchild, the neglected stepchild of global health. And I wanted to ask the panel, has this changed? And if not, why not? Do we need to rethink our narrative about global surgery? Thank you.
Anyone can jump in.
I'll say a quick word, and you're making me say something that I was going to say in my closing comments, but I'll say it right now. If you look at, with the exception of me, if you look at the panelists, the unbelievable panelists who are here today, this would not have happened 5 years ago. So when you talk about, whether we're, quote, the neglected stepchild anymore, I don't really think so. I mean, you look at these panelists, and a chancellor emeritus, a minister of health, a leader from the WHO, the executive director of UNFPA. I mean, that's just unbelievable to me that these people have taken time out of their busy schedule to come here today. And certainly it's an honor, and it speaks to what has happened in the last 5 years. So I could not be more enthused about the future, given just this commitment today, seeing these 4 incredible leaders here today.
Well,
may I have a short comment also?
Yes. So we'll make this the closing comments, if that's okay. John, did you have anything else more you wanted to say?
Well, the couple things I was going to say in my closing comments was what I'm enthused about is one, the renewed focus on the kind of the global surgical ecosystem of the workforce, the concentration on the workforce. And, you listen to Professor Jafarian talk about what Iran has done. That's just remarkable. I mean, the scale up is just dramatic. You listen to Minister today say what they've done through SALTS, and Dr. Varghese talking about the educational goals that they have within WHO. So that's something that's new and refreshing. And then the last thing I wanted to close on for my closing comment is that the funding and financing is really critical. And this is kind of, I'm going back to this USAID thing. Now is the time for countries to reach out for this type of funding, because as you saw in my opening comments, in 90 days, the USAID administrator has to go back and talk about what her plans are for spending vis-a-vis this SFOPS bill for surgery. So now is the time for ministries of health to contact USAID and say, hey, we realize that this is now a congressional mandate, and engage USAID. So that's my plug for countries to target that type of funding, because I would really like to see USAID, World Bank, Gates, et cetera, start to fund global surgery in its broader extent as part of national health planning priorities. So Key, thank you very much. And once again, thank you to the panelists. It's just amazing to see all of you here today. It's an honor to be on this panel with you. And I'm glad I consider myself kind of the warm-up band for the people who are really here as the panelists. So thank you all.
So closing remarks, we'll go to a minister and then to Sharian and Professor Jafarian, and then close out with Dr. Khanum. Minister Leah Tadesse.
Thank you very much. I also would like to really appreciate the panel. It has been an excellent discussion, and I want to just say 2 points as we close. One is the advancing this agenda of improving access and quality to essential surgical services requires a lot of pieces to it. We have mentioned all of them: the infrastructure, the training, the equipping, and advocacy, and all financing. But ultimately, it requires strong leadership, making this agenda both globally and nationally, and even at facilities level. So we need to think of enhancing strong leadership and making stronger leadership commitment also as a core as we push this agenda globally and nationally. But I also would like to emphasize that although the attention that it has received through the initiative globally, through global surgery and all the national programs and strategies that have been in place the past few years, which has brought really a lot of change, it's still underfunded and still requires more focus. So I also would like to emphasize that it needs more funding, both by governments, but also particularly by donors, to make it a stronger system in countries, especially towards the training. And also, you may have seen in the chat box that one of our surgeons was commenting that even after they have the surgeons and the trained workforce, the setups are not enough, because this is also resource intensive. So equipping it and having the needed trained workforce requires resources. So as we elevate the agenda, the financing needs to be improved. So I also would like to call upon all donors and partners to really look into this, because this is a cross-cutting agenda that can impact so many health indicators that we have in our country. So thank you once again for this excellent session and the opportunity.
Thank you. Sharian?
Thank you. Thank you, Dr. Park. And this panel has been excellent. In closing, I just wanted to mention that surgery is the great unifier. If you look at the global public health agenda, there are multiple siloed areas. But whereas if you look at global surgery, this is something that works and cuts across all major initiatives, across the life course and across major diseases. So I think surgery has come off the neglected situation into an essential service. But I think it needs, of course, international support, but a lot of domestic policy and financing that needs to equip the surgical training capacity, and along with the surgical services by which the trained surgeons are able to provide the accurate skills that they have. In every area of the work that, at least in the area of non-communicable diseases that we do, at least in my area, we see substantial lack of coverage in rural areas. I have seen a lot of questions coming up on that. So I think we need to, again, this urban concentration of high-end capacity has to be really redistributed. And that is again something I think Iran and other countries have shown that it is possible. WHO has just observed the International Year of the Health and Care Worker. And we have actually sort of highlighted the role of surgeons, nurses, and others. And many of them had to pay a very heavy price also in COVID, which we really acknowledge and really pay our respects to them. And finally, WHO is setting up the WHO Academy in Lyon in France. And this is going to be a major step in WHO's global capacity building programs, where including simulation-based training programs and certified training programs will be available. So we are very pleased to have the support of all of you and would like to work with all of you taking this forward. And thank you very much.
Thank you. Professor Jafarian.
So first, let me thank the co-chairs and the panelists that I heard the very good talks from all the panelists. What I want to mention now is that the global surgery is still young in the global health issue. And but in the World Health Summit, I think with the initiative of John and from Harvard, and then my collaboration with him as from the Tehran University of Medical Sciences as a member of the WHS, now this initiative is going to be more and more powerful in the WHS at least. And I think in the next year that the WHS would be co-hosted by the WHO, I think we have a very good chance to disseminate it more and more in the community of global health. And I want to ask John to continue his efforts, and I will help if I could in the WHS as a member of M8 Alliance from Tehran University of Medical Sciences to more empower this concept in the global health agenda. Thank you very much, and that was a very wonderful panel.
Thank you. Dr. Khanum.
Well, let me thank the colleague from Lancet for the question, for noting that there has been progress. I would have to agree as a student of Alan Rosenfield, and then later when he coined the acronym of EMONC, Emergency Obstetric and Newborn Care. In the first few years, nobody really glommed onto it, but I think now it is regularized into our procedure. But I would still have to say that the issues we discussed today vis-a-vis surgical obstetric and anesthesiology care are still maybe neglected and undernourished. And to that extent, strong advocacy is still really needed for these issues. And birth should be safe everywhere, even in a humanitarian or a fragile context setting where a lot of preventable maternal death occurs. And UHC should incorporate this as part of essential care. It is life-saving, but it's also money-saving, and that's very clear. I didn't hear us talk much about the rehab services, which I also feel are important for the question about pediatrics, but also for elderly people who are accessing care, and in particular for UNFPA. When we talk about universal access to sexual and reproductive health, to the rights that go with it, partnership is going to be really important, again, to explain why and how this work takes place, and that you're constantly improving and making things better despite the pandemic. So hats off to the colleagues in that delivery room, because what I want to see in the delivery rooms around the world is the newborn being delivered safely, to hear that cry, and to have a mother smile rather than the opposite. So thank you for the work that you've been doing on this.
Well, thank you. I just want to say thank you to everyone, participants, and also to our all the panelists that took their time now today. I would argue that there has never been a better time than it is today to start investing in and strengthening surgical systems all over the world. We have alignment now with some funders, USAID. I don't know if John mentioned it, but Atul Gawande has been nominated to lead the global health part of USAID, and he's a global surgeon. He's the endocrine surgeon. So maybe next year we get Dr. Gawande sitting in this panel with us. Well, thank you so much for joining and have a rest of a great World Health Summit. Thank you.
Thank you so much.